Good morning, everyone. So I can still see a few people joining through from the waiting room, so we'll just start in a couple of seconds. Thank you for joining us. Right, so it's just after 10 and I can see numbers are sort of tailed to a stop in terms of coming through from the waiting room. So I'll formally start us off. So thank you and welcome to this morning's Muscles Matter 2021 online seminar on limb-girdle muscular dystrophy, which today, of course, marks Limb-Girdle Muscular Dystrophy Awareness Day. I'm Rob Burley and I'm Director of Campaigns, Care and Support at Muscular Dystrophy UK. So building on the success of our 2020 series and taking into account feedback that we received, we've continued the Muscles Matter seminars and they've become a regular feature in our calendar. They're not set to replace our physical events when we're able to run those again, but they'll certainly run alongside them. We're running 2 or 3 seminars a month and they focus on a range of general and condition-specific topics. They'll include sessions you told us you found the most useful on things like research, practical and financial support, and managing your condition. And each session has an opportunity to ask questions to our expert panel. I think it's important to note that our helpline remains available to anyone affected by muscle wasting conditions, and do please contact us if you have any questions or are in need of any support. We can help you with information and can either support you directly or point you to where you can get the support you need. So the number and email should be on the screen, but the number is 0800 652 6352, or you can email the team through info@musculardystrophyuk.org. We're very grateful to be joined by an expert panel covering a broad range of expertise on limb-girdle muscular dystrophy today. And we're also very grateful for the support of our sponsors, Sarepta, PTC Therapeutics and Roche. We're splitting the session into 2 parts and we'll begin by looking at research and then we'll move to exploring living with and managing the condition. So before we begin, a quick note on how you can ask questions or make comments throughout the session. We've had some advanced questions and we'll seek to cover those later, and we'd also like to incorporate some live input. And to do that, we'll be using the Q&A function, which you should be able to see at the bottom of your screen. Please type your question or comment and we will feed them into the discussion. To help us manage the technical side of the event, we won't be calling on questioners to ask their questions directly. Any questions we don't manage to cover or don't know the answers to, we'll seek to answer through our website or in direct contact with you afterwards. And a final reminder that we're recording this session and it will be made available over the next few days through the MDUK website. So for now, that's it from me. So to start us off this morning, I'm delighted to hand over to my colleague, Dr. Kate Adcock, who will introduce our research speakers and they'll chair that part of this morning's session. Kate, over to you.
Thank you very much, Rob, and good morning to everyone. It's great to be with you on International Limb-Girdle Awareness Day. Brilliant. And it's also my pleasure to introduce our first speakers for this morning and who will guide us through the research session of today's webinar. So first of all, I'd like to introduce Professor Volker Straub, who is the Harold Macmillan Professor of Medicine and Professor of Neuromuscular Genetics at the Institute of Translational and Clinical Research at Newcastle University. He's also the director of the university's John Walton Muscular Dystrophy Research Centre. Volker trained as a paediatric neurologist, but he has a long-standing research interest in how genetic muscle diseases, such as limb-girdle muscular dystrophy, develop, and he works with a number of model animals, such as zebrafish and mice, to better understand these conditions. But he's also really involved in translational research and is very much involved in the applying of magnetic resonance imaging, next generation sequencing, and other state-of-the-art technologies for the characterization and better understanding of neuromuscular conditions. Our other speaker in the research session this morning is Dr. Yalda Jamshidi, who is Reader in Genomic Medicine at St George's University of London, where she co-directs the Genetics Research Centre. She trained at University College London and completed her postdoctoral fellowships at the Institute of Child Health, which is also part of University College London, and at King's College London before taking up her academic position at St George's. Yalda runs a research group interested in identifying genetic variation or the changes associated with rare and common diseases, and her team takes this genetic information and carries out studies to provide greater understanding of the underlying mechanisms that cause neuromuscular conditions, again, often using zebrafish models. But first of all, I'd like to hand over to Volker, who is going to talk us through a few things this morning. So Volker, over to you.
Well, thank you very much, Kate, for the kind introduction, and actually thanks to the entire MDUK team for inviting me to the Limb-Girdle Muscular Dystrophy Awareness Day, which very timely is today in the Muscle Matters seminar series. And I'm going to focus a bit on the diagnostics, but I know that people are, of course, more interested in treatments. If you go to the next slide, you will see my disclosure statement. And on the one hand, it's really important to point out that clinicians and researchers are working with industry. I think it's a good thing, actually, but there might be biases, and that's why you have to disclose this information. I'll give you enough time to read through this. For this specific talk, I don't think that there's any real conflict, but I'll leave that, of course, to you to decide. The next slide, please. So limb-girdle muscular dystrophies are a group of diseases that present primarily with limb-girdle weakness, and that's weakness of the shoulder and the pelvic girdle muscles. And there is actually a very broad spectrum of diseases, which makes this difficult, and it's a different discussion than talking about a single disease. And if you go to the next slide, it serves to actually bring us all on the same page of what is a limb-girdle muscular dystrophy. Now, for those who have joined the International Limb-Girdle Muscular Dystrophy Conference a few weeks ago, this might look familiar because I also showed some of the similar slides at that conference. So many of you may have had a muscle biopsy, but not everyone, because we're now doing genetics. But if you look at a muscle, which is basically attached to a bone through its tendon, it is made up of little muscle fascicles or muscle bundles, as we call them. And within those muscle bundles, there are tube-like, elongated long muscle cells or fibers. And if you click, then on a muscle biopsy, if you look at a cross-section, these muscle fibers look like you see in the uppermost panel there, what I call normal. They're not really circles, they're a bit polygonal, but if you then look at the muscle biopsies that are labeled muscular dystrophy or end-stage muscular dystrophy, becomes obvious to everyone that there's a clear difference between what's normal and what we call muscular dystrophy, which is just the description for abnormal muscle. The next click. So what this shows, and also what the muscle biopsy shows, is that muscular dystrophy also means that there's a progression of the disease. And there is a boy with a muscular dystrophy in the MRI scanner, and you see a cross-section through the thighs of this boy, and at 5 years, 11 years, and 18 years. And you can see what looks darkish gray, which is muscle, is more and more replaced by something that looks white, which is fat. Now that is muscle wasting and what basically defines what a muscular dystrophy is. The next slide. So what's also important, and many of you will know this, is that within the muscle cells, we have this substance, a protein called creatine kinase. It's not really important what it does. We only use it as a marker because in muscular dystrophy, it leaks out of damaged muscle fibers. So many of you will have heard that they have a high CK or high CK blood levels. And so when we look specifically at what a limb-girdle muscular dystrophy is, then, as I said, it's a progressive muscle wasting disease. It means that there's damage in the muscle fibers, that the shoulder and pelvic girdle muscles are the ones that are primarily affected, and that all of them are genetically determined. Next slide. And the next slide shows you a bit the complexity of limb-girdle muscular dystrophies, because there are so many, and they were originally labeled LGMD 2 for so-called recessive ones and 1 for dominant ones, and that's the mode of inheritance. Now, the ones that are called 2 are the ones that are more common, the recessive ones, and they are the ones that go along with the high CK. There are many other muscle diseases that also show limb-girdle weakness, but aren't defined as limb-girdle muscular dystrophies. They have other names. Now, because we had reached the end of the alphabet with LGMD2Z, next slide, please, we changed the nomenclature, and we now call the recessive ones LGMD-R and the dominant ones LGMD-D. And the number 1 or 2 is the order of discovery. So LGMD-R1 was the first autosomal recessive limb-girdle muscular dystrophy that was described and discovered. And again, you can see that the list is very long. When the nomenclature was revised, some of the diseases that were previously defined as limb-girdle muscular dystrophy were taken out and others are added. And actually the list is still getting longer because researchers, clinicians do still define and characterize new forms of limb-girdle muscular dystrophy. Next slide, please. Now, there are so many and it makes it very difficult, but I assume that most of the people that are listening in are affected by one of the limb-girdle muscular dystrophies that are listed on this slide, that are either caused by genetic changes in the so-called calpain gene, the dysferlin gene, anoctamin 5 gene, chitin, many also by FKRP. And so there are a few forms that make up most of the limb-girdle muscular dystrophies. Next slide, please. And I should, just there was another click. I should also point out, and it is important, and some of you may be affected by diseases that are extremely rare. And when it comes now to, the next slides, which are about, treatment approaches for those that are affected by extremely rare diseases, of course, there is less research activity, less knowledge, less engagement from industry because they are so rare. And if you're diagnosed, of course, what you are really interested in is anything that can be done about it. And many of you may have seen similar slides like this one, where the drug discovery or drug development pipeline is illustrated from you start with an idea, you try to understand the disease in basic research, then ideally you have a compound that you think might work, you test it for first, often in animal models, and then you go into clinical trials. And then hopefully the trial shows that this drug works, and then the regulators will approve it, and the NHS will also reimburse it, and then you have access to the treatment. Now, the problem with this pathway, as many of you will know, is that it takes a long time. So from the idea to access to treatment is often a process that, may minimally take 10 years, often longer. But actually, there's a lot more to do before you do a clinical trial. One of the most important things is to understand the disease. What are we even trying to improve? How do we assess that patients are getting stronger if that's what we want to achieve? The next slide, please. So there are a number of additional studies that are often done. For example, natural history studies, where you try to understand the natural cause of the disease. Now, that's more observational rather than interventional. And of course, everyone is interested in interventional drug trials because then you get an active drug that hopefully works. But before you do this, you want to really understand the disease. You need to also balance costs, the time effort, the training, the infrastructure, equipment, personnel against each other. Often, actually, patient information is initially just collected in a patient registry because it's very cost effective, it's very cheap, and you can actually get a lot of patients included in a patient registry, ideally globally. In a clinical trial, on the other hand, where the investigation requires a lot more investment, but the data are more robust, you might only include a few patients. So coming to the next slide. What is really encouraging in the field of limb-girdle muscular dystrophies is that over the past years and ongoing right now, there are more and more so-called natural history studies, observational studies that try to understand the disease cause. Now, I showed you that there are more than 30 different limb-girdle muscular dystrophies, but for the most common forms, there are now natural history studies in LGMD2I or R9, which this is caused by FKRP mutations, in dystrophinopathy, which is LGMD2B or R2, then calpainopathy, sarcoglycanopathies. There's also a big consortium, an international consortium now, the GRASP LGMD consortium, where sites in the US and across Europe work on those natural history studies. Now, these studies are really, really important, and the next slide, please, to actually develop methods that allow you to specifically assess patients. Because if you develop a drug, the regulators want to know precisely how did you assess your drug effect. This is just an example of a large international study that we are coordinating here in Newcastle, and Anna Mayhew and myself are the PIs for this study with 15 centers across, 15 countries across several continents. And next slide, within this study, for example, and I'm not going into the details of the slide, it just shows you that assessing patients and having a robust way to assess patients needs to be based on robust data. And we have established now an assessment method that we call the North Star assessment for limb-girdle type muscular dystrophies. That, next slide please, is now starting to be used in a number of interventional clinical trials. And this is probably the most important slide, and it's one of my last slides, because it just summarizes some of the activities that are currently going on in the field of limb-girdle muscular dystrophy. Now, no one is right now missing any opportunity in terms of access to treatment, because there's no treatment that has globally been approved for limb-girdle muscular dystrophy. But there is a lot of trial activity, and a number of interventional trials are ongoing. And I've just listed a few companies here or organizations: Genethon in France, Sarepta Therapeutics from the US, AskBio from the US. And I've also listed there some other companies, PTC, ML Biosolutions. There are also academics that are involved in looking at interventions for limb-girdle muscular dystrophy. Now, often you hear about so-called pipelines. So companies start with one form, and then hopefully, if they have a successful drug, might modify this drug or use the same drug for another form of limb-girdle muscular dystrophy. The most probably exciting developments right now are around gene therapy. And so first patients have now been dosed, or I wouldn't say treated yet really, because we don't know how effective the treatment is, but they have been dosed, they have been administered with gene therapy for the sarcoglycanopathy, a specific form, beta sarcoglycanopathy. And this is now also happening for LGMD2I, and there are a few companies that are involved in this. So we still have to wait and see, because what patients want, and clinicians, of course, and everyone, and companies, is safe and effective treatments. And the clinical trials serve really to answer whether a drug is safe and effective. So it's very exciting times. To the next slide, and I think that's my last slide then. Yeah, in conclusion, it's a very exciting time to work in the field of limb-girdle muscular dystrophy. For patients and families, it is even more important now to have a correct, confirmed genetic diagnosis, not just because of the relevance and the impact for a family, for your own job choice or prognosis, or to prevent complications, but also because the precise diagnosis will most likely be an inclusion criteria for clinical trial. And of course, for future molecular therapies, you need to know what form of limb-girdle muscular dystrophy you have. So that is very important. And then let's hope that the treatments that are currently in trials will be effective and safe. And the next slide. So with this, I thank you very much for your attention, and I'm looking forward to the question and answer session then. Thank you.
Thank you very much, Volker. That was really fantastic. And we're already getting some great questions coming in. But before we move to those questions, let's hear from Dr. Jamshidi. So I think there's a video of Dr. Jamshidi's talk. Over to you.
Hello, my name is Yalda Jamshidi, and I'm a geneticist based at St George's, University of London. I'm going to be talking briefly today about limb-girdle muscular dystrophy from a geneticist's point of view, and sharing some of the work my group has been doing recently. Limb-girdle muscular dystrophies are a group of rare hereditary muscle diseases affecting approximately 2 in 100,000 people. This is much rarer than Duchenne muscular dystrophy, for example, which is one of the most common and severe forms. Many different subtypes exist, each of which are the consequence of changes at the DNA level, and so far we know of at least 30 different genes which can be involved in LGMD. In order to provide a genetic diagnosis, gene testing is often carried out. It is currently available at low cost thanks to the rapid development of DNA sequencing techniques, which allows us to relatively quickly screen a patient's DNA for possible changes that could be causing the condition. In a healthcare setting, the screening involves testing genes known to cause disease. And importantly, a genetic diagnosis can provide disease-specific management and allow testing of other family members and appropriate genetic counselling for the family. Some of the genes linked to limb-girdle muscular dystrophy have been studied extensively in humans and also various animal models. In some cases, these investigations have led to human clinical trials of potential disease-modifying therapies, including gene replacement strategies for individual subtypes using adeno-associated virus or AAV vectors. But currently there are no FDA-approved disease therapies for any subtype of LGMD. And unfortunately, there are a large number of LGMD cases, sometimes up to 40%, where we can't find the DNA change responsible. This means that we can't provide optimal management and genetic counselling to the family, and they will likely not be eligible for clinical trials or future novel therapies targeting specific genes. So this is where we come in. Thanks to funding from Muscular Dystrophy UK, we are able to further investigate 15 families with limb-girdle muscular dystrophy who have not received a diagnosis despite healthcare genetic screening carried out at some point over the past 4 years. And what are we going to do that is different and will hopefully provide a much needed diagnosis in as many of these families as possible? Well, thanks to genetics moving at an extremely fast pace, with improvements in both the technology and the data analysis techniques, this means that we can revisit the data obtained in earlier screening efforts and extend our investigation to all potential genes, not just those already known to be associated with limb-girdle muscular dystrophy. I'd like to share some of the results of what we found in our study. In one family with limb-girdle muscular dystrophy that was likely to be autosomal recessive, i.e. where we would expect to find 2 changes in the DNA, initial genetic analysis of one of the affected family members identified just a single change in a known LGMD gene, which we couldn't determine as being the defining cause. In our reanalysis, the MDUK funding allowed us to sequence a second member of the family with a more extensive sequencing approach known as whole genome sequencing. And in this sibling, we identified the original variant as well as a second variant in that same gene that had been missed the first time round. As the different sequencing techniques have some limitations, there is a chance that we can miss DNA changes that do exist, particularly in some genes that are tricky to sequence completely, and therefore applying different approaches or sequencing more than one affected individual in a family can be fruitful. In a second family, we identified 2 copies of a variant in a known myopathy gene, but interestingly the very same variant had been previously observed in a single case study, a family who had autosomal dominant limb-girdle muscular dystrophy, and in that family the age of onset was around 50. However, in our family, 2 copies of the same variant was associated with a much earlier age of onset of just 15 years. This suggests that some genes previously associated with autosomal dominant limb-girdle muscular dystrophy can also be involved in recessive forms of the condition, and in these the phenotype may be more severe. Some types of DNA changes are harder to detect with standard genetic analysis. For example, in this family, previous testing had been unsuccessful, but when we applied new methods of analysing the data, we were able to identify a deletion of 5 exons of the gene. So instead of a single DNA letter change, a large stretch of the DNA letters were missing from the gene. Here on the right you can see the grey boxes, which represent the sequence information from the patient that overlaps the exons of the gene shown just below. However, there is no sequence overlapping exons 3, 4, 5, 6 and 7. In other words, this region of the gene is missing in the patient. This demonstrated to us that it's important to continue to develop methods to analyse the DNA sequence data for different types of variants that may be missed from standard analyses. In one family, we identified a frameshift deletion in the DMD gene, which codes for the dystrophin protein and is the gene affected in patients with Duchenne muscular dystrophy. This was despite a prior negative DMD screen and highlights the overlap in phenotypes for different forms of muscular dystrophy and the need to look at all the genes when we're trying to identify the underlying genetic cause. We weren't able to determine for certain the cause in the remaining families we investigated. We do have their genetic data, which means we can continue to revisit them as methods improve. But for some of the families, we have possible new genes. However, in order to establish them as true limb-girdle muscular dystrophy genes, we need to identify more families with DNA changes in the same gene, and ultimately investigate the function of the gene using models such as the zebrafish. We hope to gain future funding to allow this work to continue, as we know from experience that the process can be successful. So in summary, our main goal is to identify the underlying genetic cause of limb-girdle muscular dystrophy. This is essential to provide appropriate healthcare management for the families involved. By learning more about the genes and sharing this information with others, we can potentially help them provide a diagnosis in some of their undiagnosed families. Our findings can also reveal important clues about how the disease develops, and in doing so, support the development of effective treatment strategies. This is really important as there is no currently approved treatment, and for rarer conditions in particular, if we can find common mechanisms across several subtypes, it can offer a quicker and more cost-effective route to development of therapies. I'd just like to end by thanking Muscular Dystrophy UK again for the funding, all the limb-girdle muscular dystrophy families who kindly agreed to take part in our study, and I'd like to mention some key members of the team: Dr. Alan Pittman, who is a bioinformatician and plays a key role in developing and applying the techniques for analysis of the DNA sequencing data, and Dr. Daniel Osborne, who is an expert in developing models of disease in zebrafish. And thank you all for listening.
Fantastic. Thank you, Yalda, and thank you, Volker. So we've had lots of questions, so I'm going to dive straight in, actually with quite a seemingly very straightforward question, but I'm not sure that we absolutely know the answer. And do we know how many people in the UK have limb-girdle muscular dystrophy, Volker, or even Yalda? Volker, you're on mute, I think.
Yeah, we can extrapolate. I mean, we have done studies in the north of England, specifically in our catchment area, about the prevalence, the frequency of limb-girdle muscular dystrophy, and could of course think, well, how does this apply to the UK? But the north has a different population than, for example, London, so it's a bit difficult. I would currently say that there is about 1 in 100,000, maybe a bit more, and then there's 60 million people, so people can do the math.
Fantastic, thank you. And what sort of age ranges? I mean, we hear of some particular conditions which generally affect younger people, but limb-girdle affects people across the lifespan. Is that correct?
Yeah, happy to answer that. Yes.
Sorry, I should direct my question.
No, I mean, so we define limb-girdle muscular dystrophy now as patients that have been able to walk, but it already implies that actually it can start very early on. So it can start in early childhood. There's some limb girdle muscular dystrophies that have a late onset in adulthood, often in the 30s, particularly LGMD 2L or R12 for unoptimal 5. So yes, I mean, it can affect adults, and it doesn't go away. It stays with you, and because it's a muscular dystrophy, as I said, it's getting worse over the course of a life. But there are very, very different causes. So someone might have a really severe limb girdle muscular dystrophy and loses the ability to walk even as a child, and then other adults might never need a wheelchair, and so that's the challenge with limb girdle muscular dystrophy, that we're not talking about one disease but about
You mentioned actually the 2L or R12, the anoctamin related limb girdle there, Volker, and you also mentioned in your talk about the need for patient registries, or the importance and the value that they bring, but not all limb girdle muscular dystrophies have got patient registries. How do we square that circle? How do we manage that?
Yes, so for some of them there are global registries. For some of them, there are also national registries, but there's currently an initiative from Creatine MD in close collaboration with patient advocacy, with all the stakeholders, to establish a limb girdle muscular dystrophy registry. So this is work in progress, but I think it's really important, and I think once it's ready to go, we will promote this and disseminate information so that patients and families feel that they can register, because often there is the fear that, well, if I'm not, who knows about me if there's a treatment coming up or a trial? How do people reach out to me? How do they not forget about me? And this is where the registry play a really important function. So this is currently all work in progress.
Fantastic. And Yelda, what we learned from some of your genetic studies and what we learned from some of the gene therapy trials, does that help us with sort of moving on to, if you like, another form of limb girdle muscular dystrophy and understanding more, or are they so very different that actually it doesn't work that way, so to speak?
So I think it provides a lot of useful information, because we still need to target the same area. We still need to have the sort of the mechanism to get the treatment to the right place. And that can be fairly generic across the different subtypes. So whilst it might not directly help your treatment in itself, it definitely helps the field move forward, so that next time round, when a subtype that is perhaps not on the list that's currently being looked at is targeted, we're way ahead of the game, and it's more about just delivering that particular gene or that subtype. So yes, it definitely does. And hopefully there will be more things in common that we can look at, biomarkers, ways of determining whether these treatments are effective, and that applies to all the subtypes when they come to clinical trials. So definitely, yes.
Brilliant, thank you. And thinking about clinical trials, Volker, you might be able to help answer this question. Do companies sort of look at what are the most common versions of limb girdle and then work on those first and then move forward? Or I mean, I'm thinking probably that not, because of some of the studies, the gene therapy study that is going on with Sarepta at the minute is not a particularly common form of limb girdle. So how do companies make those choices? Can you help?
Yeah, so in theory, yes. I mean, companies are interested in a market, and therefore you want to make sure that your patient number that you target is high. But it also depends on the preclinical, before you go into patients, research progress. And I've shown that this is a long pathway. And it happened that LGMD 2E or R4 was picked as the first one to go to trial, because it was a research group that advanced that treatment. They were interested in this very rare form, and the company felt, okay, this is the most advanced development, we'll take this into clinical trials. And then they realized, it's actually very, very rare, and it might be difficult. So sometimes companies, in hindsight, you know, are a bit disappointed that they picked the wrong disease. But because I saw that there were questions about this, generally, the more common diseases are picked first. And then we have to keep in mind that some of the diseases, and there were a few questions about, you know, JAK2, some of these diseases are so rare that there's not even a research program yet. And, you know, there are only 1 or 2 groups in the world that might know about this. And so, you know, it will take longer to get to treatments, but whatever we learn in one form is useful for any other form.
Fantastic, thank you. And Yalda, you've got your hand up.
I just wanted to add also, the problem isn't, you know, the right gene to target or the wrong gene. Sometimes the rarer forms, actually, the problem is there's not enough of people to test these treatments on. And in order to prove that, you know, the drug is working and is safe, it's very hard to do so if there's only 5 people in the world. So, you know, there is that difficulty. But also, I think the other thing to mention is sometimes the companies will also target the forms that are the most severe, because then there's more of a sort of impetus behind sort of regulatory bodies approving it. So quite often, even if something is quite rare, if it's got a very severe phenotype, it could still be a good target for the companies.
Fantastic, thank you. And actually, sort of building on what you were saying, Volker, around sort of gene therapies and understanding from the preclinical data. So before we get to the clinical trials, for example, 2L, R12, and Octamin, it's the one I'm going to remember, I think, of the new nomenclature. You know, we're still in that preclinical phase, I think, for some of these gene therapies. Do we know when it's going to sort of tip into a clinical trial for some of these? And also, do we think that the clinical trials might be coming to the UK?
So in the UK, we are currently involved in some of the natural history studies that lead to the gene therapy trials. So I can already tell that our center will be involved in gene therapy trials for limb-girdle muscular dystrophy R9, which is FKRP or 2I, also for the sarcoglycanopathies from Sarepta. So this is something that will come, assuming that there aren't any big safety concerns. And so if you look at the field right now, there are some diseases, and a very rare form of a congenital myopathy, myotubular myopathy. There were 4 patients that died in the gene therapy trial. Now, that's of course something where you need to hold everything and look very carefully. What is the risk? And sometimes the research in the animal models does not really tell you how dangerous is this for humans. So right now, I think everyone is excited about the outlook of gene therapy, but we very much need to look at the safety aspects. It's less about efficacy right now, it's how safe it is. And there aren't that many patients with limb-girdle muscular dystrophy that have yet been administered with gene therapy. The few that have, fortunately are doing fine, but I think currently the field is on high alert as well.
Fantastic, thank you. And thinking about gene therapies and actually any treatment, to be honest, is presumably the ideal dream is that we reverse the progression of the disease and people become stronger, but do companies and researchers sort of have a view as to sort of, is the aim to slow, to stop, or reverse the progression of the disease? Maybe Volker, I can turn to you first, and Yalda, if you have some comments.
So, a lot of the news that we hear about gene therapy comes from a different disease, spinal muscular atrophy. And there, the target is the nerve cell, the motor neuron, not the muscle. Now, it's almost like the perfect target because these are cells that don't divide. And once you have your, healthy gene in that cell, it stays in there. It's also that these cells are very well protected from the immune system. With muscle, it's a lot more complicated. Muscle cells can, particularly, in younger patients, still divide. Patients grow, our muscle mass grows. So there are a number of really unanswered questions yet of how effective the gene therapy will be in the long term in muscle. And therefore, this question, when do you administer the gene therapy and what to expect, coming back to your precise question, slowing down, stopping, or improving the disease. Some of this is something that the clinical trials will need to show us. And this is exactly why we do clinical trials, because we don't have the answers to these questions, which are extremely important.
Fantastic, thank you. Yalda, I don't know if there's anything you want to add to that. It was very comprehensive, so thank you very much. And there was, we've been obviously focusing quite a lot on the discussions around gene therapies, but somebody had asked a question about whether there's any experience of testosterone replacement therapy for limb girdle, and it's not something I'm aware of, and I just wondered, Volker, whether you can enlighten us.
So, I mean, we are not aware that there's a testosterone deficiency, which is more of a problem, and that's why it's more addressed in Duchenne muscular dystrophy, where you treat patients with long-term steroids, which have a counter effect to the testosterone. So for limb girdle muscular dystrophy, there isn't really a need therefore that much to think about increasing testosterone, even though it's an anabolic compound which makes people stronger. This is why bodybuilders use it as well. But so there's no research, to my knowledge, going on in this field, and I wouldn't see this as something that is viable, because people already have testosterone, and if it would do anything, the body would probably increase its production to a certain degree. But
fantastic, thank you. We've had a question from someone who's recently had a genetically confirmed diagnosis, and I'm going to read this out, of limb girdle muscular dystrophy, GMPPB, which is a very rare form. And I think the person is wondering, is there a number under the new system, so to speak, for this yet, or is this still to be reclassified?
No, I mean, the current number is R19 for that disease.
Right.
It's a very rare form indeed. It's one of the so-called dystrodysglycanopathies. I think we are starting to diagnose more and more patients in the UK with this condition, and the previous form was 2T, and yes, it's now R19.
Brilliant, thank you. It feels a bit rude, mean to sort of putting you on the spot like that, but it's fantastic, thank you. And just a question around sort of how people experience limb girdle muscular dystrophy. Are there sort of the different areas, the different muscles affected differently for different subtypes? So is the pelvic girdle perhaps affected more in some subtypes than the shoulder girdle?
Yeah, that is the case. We have to admit that people, clinicians and researchers, put quite a lot of diseases under this group, limb girdle muscular dystrophy, despite the fact that they don't all show the same symptoms. Actually, the sarcoglycanopathies, as one example, have very prominent shoulder girdle involvement. The anoctamin 5, LGMD R12 that we have mentioned a few times. Interestingly, the pelvic girdle muscles are very well preserved, and it's more the thigh muscles and sometimes also the lower legs that are more involved. And their shoulder girdle also is often completely almost normal. And people and patients have mentioned that they feel that they have, that their body is actually split, that upper body function is normal, whereas the legs are prominently involved. So the forms do show different symptoms.
And thank you, it's very helpful, thank you. And some people seem to be given a diagnosis probably of muscular dystrophy without getting that kind of more defined definition, and certainly a genetic definition. Do you have any advice as to how they could perhaps get a more thorough diagnosis so that they could potentially be involved in clinical trials in the future?
So I think that the patients who don't have a precise diagnosis need to really discuss this with their neurologist. There are diagnostic services that can look into this in a lot more detail these days than it was possible even a year ago. But then there are also people like Yalda and myself who are interested in really unraveling the molecular etiology and cause. So I think in the UK we are very well placed to provide the large majority of patients with LGMD with a precise diagnosis.
Fantastic. And if we get to a stage where we've got sort of the subtype diagnosis, what are sort of the next stages for research? How do we get more people to research in that area?
Well, Yalda, yes. I was going to say, I think that the biggest stumbling block is funding. Money is hard for everybody at the moment, and it's even more so with research because, of course, we're not usually the first in line for public funding or government funding. But ultimately, that's the limiting factor. There are plenty of researchers who are keen and interested to get involved and do the work. It's just, unfortunately, funding is a big stumbling block.
Fantastic. Thank you. Yes, I absolutely agree. And we do what we can to help support, because obviously we absolutely understand how important this is for families and for understanding and developing treatments for the future. I think we've had many research questions, and thank you both for your time and in answering them and your very helpful comments. I think that now it's probably a good time to move over to the more broader panel discussion, and I'm sure if any more research questions pop up, Rob will be able to steer them to you. So thank you both very much, and thank you everyone for providing us with such a rich discussion with the questions that you sent through. So thank you. Back to you, Rob.
Thanks, Kate, and yeah, huge thanks to Volker and Yalda, and thanks for staying with us into this section. That was a fantastic presentation and great discussion as well. Often we find with these the questions sort of spark a lot more discussion. So thanks everyone for participating. And just a reminder, if you haven't found it already, there's the Q&A button should be at the bottom of your screen. So do please keep questions coming. And as Kate says, if you haven't had a chance yet to have a question on research, do still put them in, because we will sort of loop back if we have time. So before I sort of invite any speakers to start off this next session, I'll introduce the panelists who are joining Yalda and Volker, and thank you very much for joining us today. So first of all, we have Dr. Anna Mayhew joining us. Anna is a consultant research physiotherapist at the John Walton Muscular Dystrophy Centre at Newcastle University. She has a special interest in development of robust and clinically relevant functional outcome measures for all types of neuromuscular disorders, as well as suitable patient-reported outcome measures. And since 2009, she's worked for the Newcastle Muscle Centre, where she's a consultant research physiotherapist involved in clinical and research activity for children and adults. Also joining us with a physiotherapy background is Jenny Sheehan, and Jenny is a clinical specialist paediatric physiotherapist at Evelina London Children's Hospital. She has over 30 years of experience in working in neuromuscular conditions, mostly in paediatrics, but does have some adult experience as well. Jenny runs the physiotherapy-only neuromuscular clinics, in addition to being part of the multidisciplinary team clinics at the Evelina. The service also runs outreach clinics. Jenny's involved in teaching and service development and was one of the developers and authors of the North Star Functional Assessment for Duchenne Muscular Dystrophy, which is now well recognised and used worldwide. She's also heavily involved in SMA work. She's on the steering committee for the SMA Reach Network and was involved in lots of work behind the scenes around the introduction of treatments, recent treatments for SMA, including the gene therapy that's just been made available. And lastly, but not least, Louise Halling is a professional counsellor who has a special interest in working with adults living with disability. Louise lives in the south of England and is also the mum of a 10-year-old boy. She also has limb girdle muscular dystrophy. So thank you very much for joining us. I'm going to turn first to Anna and Jenny, if I can. We've heard a lot about in the first session, some of the questions sort of covered some of the impact of limb girdle muscular dystrophy. It'd be really great to hear from you both actually about an overview of the kind of physiotherapy support that you and colleagues provide to people living with limb girdle muscular dystrophy, and why it's so important. And perhaps sort of Jenny, if I start with you from the paediatric perspective and move on through to Anna with a bit of the adult view, if that's okay.
Yeah, that's fine. Hi. Yes, so we see limb girdle muscular dystrophy not in a specialist clinic, not in a limb girdle clinic, but in a specialist neuromuscular clinic at Evelina. We are paediatrics only, so my role is to assess and advise and identify clinical problems, and then advise the local community physiotherapists on how to manage this, whether this is orthotics, physio program, strengthening, stretching, advice regarding mobility, including wheelchairs, and advice and guidance to the families. I think probably the most difficult aspect I find with limb girdle are the number of new diagnoses we get in teenage years. And I think that is particularly difficult for teenagers to come to terms with. So that's quite difficult to get them on the right track before we transition them into adults. So that's my role really, is guiding the physical management and advising the local physios in the community. Physios in the community might only ever see one child with a limb girdle muscular dystrophy. And there is a bit of a tendency to assume that everything is like Duchenne. So I think there's quite a lot of guidance and teaching required there.
Thanks, Jenny. I suspect we'll come back on that point you raised about dealing with the diagnosis in your teens, and that's a really interesting point. So, but Anna, over to you first in terms of how does that transition through into support for adults then, in terms of that sort of physiotherapy support, and also sort of building, I guess, on a question we had in the first session. Actually, do you still see as adults then, I presume, sort of newly diagnosed patients as well?
Yes, very much so. So a big part of our early role is actually in the diagnostic clinic along with the clinician, where the physiotherapy assessment relating to the pattern of muscle weakness can help the doctor to plan the right way forward. And that's something that we discuss both with the patient and together about how someone like Volker will take that forward in terms of testing and which panels to run. We are very involved, therefore, but also in the management, even in diagnostic clinic, because sometimes by the time they get to the diagnostic clinic, they've been round the houses very, very many times. And I think some of you will be familiar with that one. So we try as quickly as we can to make sure that it isn't just about measurement when they come to clinic, it is about management. Now, sometimes we need the measurements to help with that, but it will range from, as Jenny said, perhaps to do with orthotics. We give a lot of advice related to exercise and activity on what's best and what's most useful and what perhaps is not beneficial and could be even harmful. There is a lot of advice about promoting independence and functionality in different ways, but also managing that decline with dignity and really helping patients make that fight to get what they need. Because one of the big things about transition is that the community services are not available. That's been highlighted before. It's very difficult for them to access physiotherapy, hydrotherapy, etc. So we spend a lot of time writing letters, making telephone calls, doing what we can to support them and help move things forward. We also do a respiratory assessment because some of these limb girdle diseases are associated with respiratory difficulties, and so we make that assessment on a regular basis, and we'll then go on to make referrals and support them on that side as well. So that's just for starters.
Just for a good phrase, just for starters. Volker, if I could come to you next. We've now heard sort of Anna and Jenny talk about the physio element, and throughout the session so far, we've alluded to terms like multidisciplinary team and the various other specialists. But could you just give us an overview of the team that will be sort of almost built around someone living with limb girdle, and that you have to coordinate as the consultant?
Yes, so we are the national referral center as well for the diagnosis of limb girdle muscular dystrophy and providing advice. And so it starts actually also with a diagnostic team. There are people that are in the lab, in the molecular lab. There are people that look at muscle biopsies. There are people that look at MRI scans. So there's that aspect that is really important, the diagnostics. And it doesn't end with one patient, because there might be family implications and you test more. And that involves then the genetic nurses as well, or counselors that are involved. And then Anna mentioned that when it comes to patient assessment and patient management, the physios are often more relevant than the doctor, because we don't yet have a drug to prescribe. And it's a lot about what kind of orthotics or exercises you need. So physio team is very important to be involved. But then it's about benefits. How does this impact on benefits on housing? So ideally, you want to have a care advisor. MDUK has like a fundamental role in providing care advisors initially. So that's an important member of the team as well. And then there are complications that you have to anticipate. It can be the heart involvement, it can be the respiratory involvement. So you have to reach out to those teams and work with them as well. And all of a sudden you realize how complex it is to manage the needs of a patient or family with limb girdle muscular dystrophy. And I think that the real strength is if you are seen, ideally, by a team that provides all of these different components. And in the UK, I think we are, extremely good in that, working also with patient advocacy, working in networks across centers. So we don't have a specific limb girdle network yet, but we have other networks of neuromuscular centers. And it's often the same clinicians and teams that see a patient with a limb girdle muscular dystrophy, or Duchenne muscular dystrophy or spinal muscular atrophy.
Thanks, Volker. Louise, I wanted to come to you last, because I think you're probably, you are the biggest expert we have on living with limb girdle muscular dystrophy on the panel. And also I thought it'd be interesting to hear your reflections on what you've heard so far in terms of that complex support. And it'd be great to hear your experience of accessing that support and how and your journey with limb girdle.
Yeah, I mean, I think as a patient, there's something extremely reassuring about having a whole team of people that care about you, ultimately. It's interesting actually, because we've recently moved to a new area, and I've found a new GP who, and you never quite know, when you're finding it could be anyone. And I've only ever met her on the phone, but she seemed absolutely lovely. And I had to get a new referral back to the centre in Southampton where I was years ago, under Simon Hammonds there. And she was we were just having a bit of a chat with the GP, and she sort of said something like, oh, obviously in terms of them not being a treatment currently, kind of, does it feel a bit pointless almost, kind of going along to your annual appointment type thing? I mean, she didn't quite put it like that, but that was what she was saying. And I said, oh no, not at all, because although on one level you could argue that, I go once a year, get told the same thing, keep going, we don't know, there's nothing to help you, effectively, but it would be so terribly lonely and isolating and frightening to feel I had nowhere to go, that there weren't people I could ask or be reassured by or know, like what you've talked about, that if a treatment was to come up, if something became possible, that I wouldn't be left behind, So, even though at times it can feel as though, sort of what's the point, because there is no treatment, there is something, I mean, we need that connection and that reassurance. And I think also we're those of us that are living with, muscular dystrophies and living with disability, therefore with level of fatigue and in some cases pain, etc. We're already so tired that to know that there's a whole, well, there's a charity, there's MDUK, there are doctors, there are researchers, there are people in the lab, there are physios, there are care providers working on our behalf, advocating for us, doing the work behind the scenes, because we can't do it for ourselves. You know, it's absolutely vital. And for me as a patient, I find that invaluable. And you know, we've lived, well, I started off in Newcastle actually because I'm from the borders of Scotland. So when I was 19 and first diagnosed, that was quite near home. And then, you know, I've moved and lived all over the place and had, well, in fact, lived in Sydney for 6 years and was under Marilee Needham, who some of you might know out there. And, you know, knowing that, you know, there is even this network, like she knew the doctors over here. And, you know, I felt all the time like, you know, I was being cared for, and you know, it's vital.
Thanks, Louise. You mentioned then the risk of isolation and the kind of the sense that you didn't want to be sort of left behind. Straying into a professional role, is that something that comes through sort of quite a lot from the people you support who have disabilities like limb girdle, and also what kind of support do you offer around things like the Jenny and you have both mentioned that experience of diagnosis. Are they the sort of common themes that come through in your professional experience as well?
I mean, I think it's probably first important to say I'm not obviously a genetic counsellor, because that's mentioned quite often. It's obviously a different realm and they're specifically trained in that arena. And usually by the time I see someone, whether it's someone with a totally different disability or with a muscular dystrophy, they are, you know, they've already had their diagnosis. I haven't really seen many people who've literally been told last week, you know, I've got it. But I think, yeah, the biggest themes, yeah, there is a sort of isolation. So I do hear, just so that you know, when I do see patients that have muscular dystrophies, I hear through them about their experiences of being supported by teams at hospitals and clinics across the UK and how positive that is. So I hear that secondhand. But in terms of just that sense, I think people come to see me because they know that I get it. So there's something reassuring for them, even if they have a different type of MD or have MS or something, that I am someone that actually there's a base level understanding of certain things that they don't need to explain to me because I get it, you know. And I think that therefore eases the isolation, you know, especially in younger people, you know, that, for example, you know, someone who might be facing getting a mobility scooter for the first time or something, and this sort of journey around that, and in the rest of their life, so it might be someone in their 30s thinking about, do I need a mobility scooter so that I can have more freedom to go out with my family? And what they'll hear on the outside, as it were, is, you know, someone go, oh yeah, my granny's got one of those, you know, as if that's somehow relevant. And it feels slightly offensive, it feels really difficult. And I think kind of living with this sort of microaggression, you know, I know it's been talked a lot around race in the public sphere, but I don't think that many people realize how much of that we hear all the time. You know, when I go out in my mobility scooter, I would say, oh, you know, very regularly, at least once a month, I'll hear someone will go, I could do with one of those. And, you know, you're hearing these things over and over again. And, you know, I've started to say, oh, all right, then I'll swap you. You can have my disability and you can have this scooter for free and I'll have your legs so that I can walk down the beach. How about that? You know, there's this constant sort of coming to terms with loss, basically. And I think that is the key of the work that I do, that it's a grief journey, it's a loss journey, you know, loss of muscle, loss of independence, loss of future possibilities, loss of finance in some cases because of having to cut down on the amount you could work. You know, it can be very isolating for people.
Thanks, Louise. I think that, yeah, the theme there you've touched on, kind of empathy and understanding when you're supporting people, it really rings a bell with me in terms of a lot of work we do on why we push for access to specialist psychiatric support for people living with a muscle wasting condition, because people often tell us it doesn't help when you have to explain your condition to someone who doesn't understand what a muscle wasting condition is, and therefore that's why it's so important. So yeah, that's definitely a parallel there. Volker mentioned that, I don't know who's just being polite because Jenny and Anna are on the call, but how crucial physiotherapy is and often more important than the doctor. We've had a number of questions that I think are physio related, so I'm going to bracket those together now, if that's okay, and sort of concentrate on Anna and Jenny with the first few questions. The first question, and some of these we had in advance. So the first is that someone has a weakness in their backbone day by day and is not able to maintain body balance, and sometimes when walking can suddenly fall down. Is there a way that they can improve weakness and body balance? Is that something that physio can help with? I suppose they're an adult, so Anna, I don't know if I want to start with you.
Yeah, I mean, obviously, this comes with a caveat that until you know why those things are happening, I can't comment on a specific condition. We know that exercise and exercises and activity can help build the muscle that is working well, and that can have an impact to stabilize, hold somebody in a plateau for a certain amount of time. And we have had instances where patients have taken up gym activity for the year, or a lot of hydrotherapy, and we've actually noticed some significant improvements in their motor ability. So I think that exercise and activity can really help. But there are times when the progression of the disease means that there's very little good muscle, if I can put that in brackets, to work with, and that can be more difficult. But there can be other things that could help. There could be mobility aids, there could be orthotics, there could be some pacing advice, etc. to give. So it's my frustration that there isn't more local community support for individuals in that instance, and we try within our clinics to give as much information as possible, but also have an open line or an email system where individuals can get back in touch with us, because sometimes these problems don't arise when you have your yearly appointment, and you want a little bit of help and support throughout the year, and unfortunately we can't offer more frequent appointments within the specialist centres.
And linked to that, I think I sort of may have a clue at the answer, but someone asked in advance, is there general advice on sort of general exercise that's good for people living with limb girdle, or really is it around working with an individual to understand how the condition's affecting them and therefore tailoring exercise?
Yeah, I think there is general advice to give, and there are some documents on the MDUK website about adults and exercise and do's and don'ts and advice on building things up slowly, not starting too big. I mean, Jenny, and I'm sure she's very aware, patients go, well, I'm going to go to the gym, and they go for way too long and they go way too hard, and then they can't do anything for a whole week. It's been too much. So, there are general guidelines about starting small, making sure that things are safe, being aware of pain and how you feel the next day, and that using a general guideline of little and often. It's better to do something for a shorter period of time, 2 or 3 times a week, than going for hell for leather once a week and ending up on the floor. And I think it's also recognizing that exercise can be activity, it can be housework, it can be, if you're very weak, being out in an electric wheelchair, just going over on uneven ground, because that's working the muscles in your trunk. So it isn't all about, we're not talking about running and jogging and cycling. There's a whole range of activities that are very much exercising your muscles.
Jenny, have you got anything to add to that from a sort of child's perspective as well?
Yes, I agree everything that Anna said. I think with children, it's slightly different in some ways, because they're usually in mainstream school and they have PE lessons and they want to do what their friends are doing. And that's quite hard to manage, because there are some activities they can do, there are some that need to be adapted. And what we don't want to hear, but unfortunately we do hear quite a lot, what do you do in PE? I sit and watch. And that's absolutely not what we want. We want the community physio to go in and advise on a programme that is appropriate. And it might be that they can join in for half the PE lesson. It might be that the teacher can do, the whole class can do stretches or gentle activities that the child can join in, and then move on to what they would be doing, and the affected child has something else. But I think it's really hard for children to see what their friends are doing and they want to do the same. So it's finding a way so that they can participate. And I think a similar thing is, which is sort of touching on a different topic, but school trips. And they want to go on the school trips, and of course they want to go on the school trips, but we're always advising, you know, maybe you need to use the wheelchair to get from the coach to the castle or whatever, and then do the fun bit of exploring, saving your energy for that. And that is activity and that is exercise, but it's not pushing them so they can't enjoy that activity. And I think that's probably harder for children than for adults. As adults, we all choose whether we want to exercise or we don't. We know that we should, but children sort of can't escape it in a way. So yeah, but as Anna said, same thing, little and often, and not pushing. And probably the one thing that suits everybody would be swimming, because everybody can do it at their own level with whatever support they need, and which, you know, raises the lack of hydrotherapy, which unfortunately is widespread, and even more so since COVID.
Can I just interject there? So, and when Jenny talks about swimming, we don't necessarily mean swimming, we mean about getting in the water. And so sometimes that supported nature of being in the pool and walking and stepping sideways and moving backwards and using the buoyancy of the water to exercise your arms that are a little bit weak can be really beneficial. So it isn't actually about traditional strokes, if you like. And I can see Jenny smiling, and she agrees with me there. One of the things that we're looking at now for starting with one subtype, dysferlinopathy, is looking at developing a standard of care. And we are using the research, natural history study, to find out more about what people have access to, what they don't have access to, what we as therapists would be recommending, what the doctor would be recommending, and using that information to fuel a discussion and the preparation of a standard of care in a certain subtype, which we think that will be very applicable beyond that subtype. So that's something that we're doing along with the ENMC, which I can't remember what it stands for now. Volker can fill in, but it's a workshop that allows which allows a group of experts to get together to kind of help us prepare that kind of work. And so the idea is we're trying to close the gap between research and clinics. So Volker talked about developing a new scale that we use in research. So the North Star scale for limb girdle type muscular dystrophies, the NSAD, but that's something that we're using in clinic. And of course, that means that everybody, whether they're in research or a clinic, is getting the same assessment, which can be very helpful when it comes to looking to see if patients are eligible for a clinical trial. It also means that we're upskilling more therapists in those assessments, which will also be helpful if we're looking at clinical trials across the UK. Can I make one more point whilst I'm here? And it was just a little bit about coming to clinic appointments. And I know that, you know, current circumstances has made that quite frightening for some people, and they're not wanting to come to face. And I think it's something that we're also working on, that remote assessment. We know that there are means of doing respiratory assessments remotely. We can use video links to a certain extent. And I think we can make the individual's voice heard more clearly when it comes to patient-reported outcome measures, because sometimes those clinic visits come with a lot of pressure. People are very tired by the time they get here. And so actually the information taken from a patient report can be very useful. And that's something that we're working on in other diseases, but I hope not neglecting in limb girdle. And it's something that we've done quite a lot of work through the COS2 study and patient-reported outcome measures. Sorry.
Thank you. No, thanks. That's great. We're having loads of questions coming, which is fantastic. Someone in their questions has asked about seated exercise. So I think just to flag that we did a live session last year that's still available on our website with a physio running through some seated exercises. So definitely take a look at that. I think we'll send an email around to participants in this session with a series of links after this. And Anna wants to come back in on that as well.
There's also some nice YouTube links on seated, standing and supine exercises related to Pilates. which we can provide and make sure are distributed. Really nice videos to get people started and engaged.
Fantastic. Louise, I caught you nodding in vigorous agreement on the points around swimming and lacking access to hydrotherapy. Is that a form of exercise that you find really useful, and kind of what's your experience?
Yeah, so I swim 3 times a week and have done for years. And obviously COVID, had a huge impact. I know I'm not alone in that. And because I've done quite a bit of radio work with Radio 4 and stuff. And I ended up on 5 Live with Nikki Campbell talking about swimming during lockdown, because it's obviously I could appreciate it was a huge national crisis, and there were bigger fish to fry, etc. But I think when it came to like the second lockdown, just the complete lack of understanding of the impact of people with various disabilities that couldn't have access to swimming pools. It's just, for sure I've gone downhill, and I'm sure I'm not alone, and I'm absolutely certain that the lack of swimming had an impact on that. But yeah, and I think it kind of raises the point, whether it's with hydrotherapy or swimming pools, and about how expensive disability is. Not necessarily swimming, because it's probably not as expensive as some things, but it's to go to sort of a council swimming pool, that's fine, and that is what I currently do actually. But when you're swimming so much, when you get so cold, when it takes you so long to get changed, and the changing rooms are freezing cold, and you need the extra support. Frankly, it would be nice to be able to go to an expensive private gym, but what about the costs? And I think that also comes into counselling and therapy. I run my own private business. It's the only work that I do. I work very part-time because of my energy levels and being a mum and everything. So I have to charge properly for my service. So if people can afford £50 an hour to come and talk to me, great. And I have to charge that, but and by no means can everybody afford that. And so what is actually really available to people, and if they can see their GP and they do get a referral and they wait 3 months to see who's probably a CPT therapist who can be helpful, but 6 sessions with a CBT therapist, whilst I'm not going to knock that in any way, is probably not going to get to the root of somebody's grief over this huge diagnosis that they're living with, that their family's living with, the impact on their life. And it's just so hard that the resources are not there. And obviously I know Muscular Dystrophy UK is amazing, and I know that mental health is a big part of what you do and try to fund, but it's so sad really that it's such a neglected area.
Yeah, thanks, Louise. I think as well, it's worth highlighting that you're absolutely right in terms of your sense of a decline because of lockdown, and that was a theme that came out really strongly in our Shining a Light report that we published just a month or so ago, as did the sort of lack of access to the kind of specialist facilities. I think what was worrying from our perspective, and something that we're dedicated to work on for the next 12 to 18 months, was also the number of neuromuscular services who talked about fewer new diagnoses. So there's a sense that not only is provision lacking for those already in the system, there's actually a large number of people who are about to come into the system and have had more decline than they would have done had it not been for COVID. I'm going to move us on to another topic that's come through the questions that both now live and also in advance, and I think probably turn to Volker. A couple of people have asked about the importance of diet and nutrition. And is that a really sort of key element of managing limb girdle, and what kind of advice do you provide for that?
So I think we have to distinguish here between, is there anything that can be done specifically, and a generally healthy, balanced diet. So there's nothing that we know where there's any deficiency in a limb girdle muscular dystrophy that could be compensated through, a proper diet. But a balanced, healthy diet, and that includes definitely diets that make that are not calorie rich. For example, if you're overweight and obesity in anyone with a muscle wasting or muscle weakness is more difficult for that patient. And then vitamin D is the one thing where if you are already fatigable and you have vitamin D deficiency, you might be more fatigable. But that's not specific again for limb-girdle. It's basically for most people. For any muscle disease, maybe even more. So no, there's nothing specifically about the diet, but you know, I think it's important to have a healthy, balanced diet. If you have a cardiac disease as well, you know, then in a cardiomyopathy, again, there is a balanced diet that is even more important then. So I think, you know, it will depend a bit on your specific disease and discuss it with your GP. But you can't improve your limb-girdle muscular dystrophy through a specific diet.
Thanks, Volker. That's really helpful. We've had a couple of questions sparked by the sort of the discussion about physio, but I think are relevant to then a couple of questions in the comments around more generally about accessing specialist services. So I guess I'll stick with you, Volker, and then come on to the specialist physio. But someone's asked if they're not connected to a sort of specialist muscle centre, how should their condition be managed, and how does sort of referrals work if you're not near a Newcastle or an Oxford or one of the London centres?
Yeah, so it is the challenge. I mean, clearly, because you can't expect GPs to be familiar with, you know, the spectrum of rare diseases. Now, this is where MDUK, and it's not that I'm flattering MDUK or before the physiotherapists, plays an important role. So, you know, this is where we would also advise people, you know, go to the MDUK website and see, you know, what kind of information is available. If you really think that you don't get the care that you should get, you can ask for a referral. And, you know, we, as probably many other neuromuscular centers, would then be happy to see a patient and provide advice. It doesn't mean that you need to have long-term follow-up care through a specialist center. You know, it might be okay to be seen once every 5 years or so. So it depends on, you know, what disease you have, what the complications are. But I think this is where you need to make sure that you use the information that is there through either, I mean, I think mainly MDUK in the UK now, you know, through the leaflets that are provided. And sometimes, I mean, our advice, I just actually diagnosed a limb-girdle patient yesterday in the clinic, provided the diagnosis. And my message was, you know, you are now, with this discussion that I'm having with you about your disease, you're becoming the expert. And it's a strange concept sometimes for a patient to say, well, how can that be? You know, I'm going to the healthcare professional because I need expert advice. But in rare diseases, actually, you have to become the expert as well, because you may need to advise your GP. Look, I don't need cardiac checkups because in my form of limb-girdle muscular dystrophy, cardiac involvement isn't a problem. Or you need to say, actually, I need a cardiac referral because in my disease, cardiac involvement is a problem. So unfortunately, with rare diseases, that's sometimes really important. You need to know about your condition and you need to also be involved in your own management and care coordination.
Thanks, Volker. Before I come to Jenny and Anna, I think it's a useful place to just reflect on, yeah, what MDUK is here to help people with. So absolutely, do get in touch with us. The email address, which I can remember off the top of my head, is info@musculardystrophyuk.org. And I'll remind people of the helpline number towards the end of the session. But something that has been sparked actually in the comments quite a lot from things Louise was saying is around just that shared experience of living with limb-girdle muscular dystrophy. And if you do contact us through that email address or via phone, we MDUK facilitates things called muscle groups, which are local groups of people who are living with or affected by a muscle wasting condition to really have those informal chats. And I often hear from some expert local speakers, but primarily it's around connecting people. We're doing those virtually at the moment because of the sort of COVID restrictions, but we're hoping to reopen those in the near future. And also we do offer a peer support service. We've got some fantastic peer support volunteers who are very happy to be contacted by people who are perhaps going through something they've been through in the past or want to understand a bit more about the condition they've been diagnosed with. So do get in touch with us. We are here to help. Anna and Jenny, there was a specific question around how to access specialist physio. So I guess the question is, how would someone get a referral to specialist physio? And if that isn't possible, how do you interlink with sort of community physios perhaps to help upskill them if they've got people they're seeing with a muscle wasting condition?
I would say to access specialist physio, it has to be through one of the neuromuscular centres in the UK. And as Volker said, that it doesn't mean that you have to come very regularly, but at least if they come and we can point you in the right direction. And part of our role is we always write to the community physiotherapist, which is obviously easier in paediatrics because it's a better service than in adults, and advise them on what they need to do. And then we've opened the doorway for the family or the physiotherapist to contact us and ask for further advice. I think you have to be a little bit careful, and you know, I'm saying this, I've worked for years and years in the NHS, but I do private work as well. But you have to be very careful if you're looking for a private physiotherapist that is somebody that does have an understanding of a rare disease. So you have to be a little bit wary if that's the route you're going. So for specialist physiotherapy, I would always say your starting point is the local neuromuscular centre.
Thanks, Jenny. Anna, anything to add from that?
Yeah, it was just to say that sometimes the specialist physiotherapist you need is not a neuromuscular therapist. If you have had an injury or a fall and it's kind of what we'd call a musculoskeletal problem, then sometimes you need to access that expert within your GP surgery or within your local services. However, as we've already said, they're sometimes very nervous of dealing with neuromuscular. So we have created some links where we can liaise with those professionals about the impact of the condition and what they may or may not expect in terms of recovery, or it may be taking a little bit longer. We have had some success in engaging with like neuro rehab teams in adult services, or the rehabilitation team, where sometimes there's kind of, you know, limited physiotherapy, and we have done, certainly in the north of England, we've tried to do some specific training sessions with a group of therapists. All of that's become very difficult. We do have a resource for physiotherapists called opentat.net, which is funded by MDUK, which is about very much my work in building up a website that has useful resources about assessing and managing neuromuscular conditions. And we do have a section on limb-girdle muscular dystrophy. And along those lines, I have begun to develop podcasts that are useful for therapists in understanding certain aspects of a particular disease or in general neuromuscular. But some of them are aimed at patients. So at the moment, there's none specific for limb-girdle, but that is something that I have just embarked upon. And I think we could do some really good work there, perhaps around exercise or something quite specific with limb-girdle.
I've just realised I was on mute there, apologies. Louise, we've had a question or a comment about your background, your physical background actually behind you, about whether that's an artwork or hand grips. And actually that sparked me to wonder if you could share a little bit about any adaptations you've made around the home that you might want to share.
Yeah, sure. Well, this is actually a piece of art that I did with some curtain pole rings that were sitting around and I didn't want to go to waste. So that's the answer to that. Yeah, I have a lot of adaptations in our home. First of all, the stair lift, which is key. I mean, obviously, in some ways, it would make more sense for us to live in a bungalow. But as most people know, in most parts of the country, bungalows are much more expensive and smaller. So a stair lift is the best option for us. I have handrails around the toilets. We've got 2 toilets, and also those higher up toilets. So it's a normal loo, but it's a higher level. I'm lucky enough to have a sort of off-road mobility scooter, which means that I can get onto the beach, well, as long as the sand's not too soft, and lots of other rough terrain. I have a manual wheelchair, and I walk with a walker, with like a wheeled walker rollator. And what else in the house? We actually, because we have moved in here fairly recently, there were 2 steps up to the front door, and we had a ramp, like a proper ramp, like made of sort of concrete, or not concrete, but it's properly built, up to the front door, which actually, you know, is the whole financial thing again. My dad kindly offered to pay for that ramp, and it was £1,850. Now, of course, we could have done it more cheaply with a kind of metal secondhand eBay job or something, but you know, we kind of wanted it to look nice. But you know, that's just another example of living well with disability costs money. And I do have I'm lucky enough to have the high rate PIP allowance, which helps us to pay for a housekeeper. So that's what we use the money for. And we have someone that comes in for 1 hour a day, Monday to Friday, and she does like a load of washing, does the dishwasher, changes the beds, hoovers, cleans the loo, that kind of thing, because that just helps us to manage as a family. And so, yeah, I mean, I guess I'm lucky that we have the sort of ability to make these choices and make these adaptations. But, you know, by no means does everybody have that kind of privilege, I suppose. But I think also what's come up from some of your discussion is also about how different people cope with their disease in different ways. And, you know, for some people, being part of a support group, as in a local support group, can be like absolutely invaluable, and it does provide that connection. For others, like myself, actually, that's not something that I've ever partaken in, and that's partly because I'm, you know, have a lot of support generally in my life. But I think for me, and it might be different now actually, but certainly in the early days, you know, sort of when I was in my 20s and such, like, you know, it was actually too confronting to be in a room of people with different various levels of the disease, especially when I was less severe at that point. And that just felt overwhelming. For others, that need for support is very, you know, sort of pressing. And so I think also for some people, I think throwing themselves into finding out as much about the medical research as they possibly can. I think this is really relevant to healthcare professionals, because, you know, people have loads of questions and they want lots of answers, and they're, you know, looking into like research in America. That's always the one. Have you looked into research in America for some reason, as if America would have more than here? And but it's also a way of coping, you know, to have to answer those questions. For others, it's like, well, okay, I accept that right now there's no treatment. I'm just going to go and live my life the best I can. So I think that we all have to be really aware that each individual with limb girdle or any dystrophy is dealing with it emotionally, how they need to deal with it, and also their carers and families as well.
Thanks, Louise. I should say as well that so MDUK has a very comprehensive adaptations manual that I think was co-written by people living with muscle wasting conditions, sharing their own experience. And I know that also there's some videos I think available through our YouTube channel of one of another volunteer who lives with limb girdle, walking people through the adaptations he's made to his home, which might be quite a useful resource. And also, yeah, do get in touch with us. Louise mentioned personal independence payments. If you are struggling to access benefits, do give us a call, because that's the kind of thing we can definitely help with. Volker, you've raised your hand.
Sorry, I was just going to say MDUK really helped me with my application. So, you know, it was, I'm absolutely sure I wouldn't have been offered the full rate that I was without their help. So definitely talking to someone on the advocacy team if you're making the application is really a good thing to do.
Thanks, Louise. I'm glad to hear you were helped. And yeah, absolutely. So over half the calls we take and the cases we support are with PIP and helping people with the application in the first place. And also, if there's a problem with the application, we've got a very high success rate. So yeah, do get in touch. Volker, you raised your hand.
Yes, just to briefly follow on from what Louise said about, you know, research in the States or anywhere else in the world. So I think the good news is, and we make this very clear in our clinic as well, that there is no need, that's my view, for patients or families from the UK to, you know, look into research in the US or anywhere else. In the UK, we are leading a lot of the research, particularly the clinical research around limb girdle muscular dystrophy. But what's more important, we are very well connected worldwide. I mean, that is the advantage of the rare disease field, that because nationally there are only a few patients, you have to work internationally to really change things. And, you know, Anna and I have both mentioned the dysphyllinopathy study as one example, and you saw the slide. You know, this is a global study. So the people that work on limb-girdle muscular dystrophy worldwide are connected to us, or vice versa, we are connected to them. So you're not missing any opportunity, I think, if you are diagnosed with limb-girdle in the UK. That's important.
Thanks, Volker. I'm going to stick with you, but possibly bring in Anna and Jenny as well. We've had a few questions around progression of the condition, and one specific one that kind of I think probably helps would talk around progression more generally. But someone who was diagnosed 20 plus years ago, and it began with affecting sort of the pelvis and legs, but over time has started to affect shoulder and arms, and become much weaker. Is that a common pattern, or is it sort of different in each individual?
So it probably depends on the type of limb-girdle muscular dystrophy here. We have discussed this briefly before, that not all of the forms, for example, show prominent shoulder and upper limb involvement at the beginning, and it might only manifest later on. But then there are other forms where, I mentioned the sarcoglycanopathies, where the shoulders are particularly involved. So depends a bit on the form, but also it depends on the genetic change specifically for that form. So ultimately, when it comes to patients, it always boils down to the individual patient. This is actually, and again, it's not to flatter the physiotherapists, where it is important, this individual assessment and the individual management. But at a day like this, of course, we have to talk a bit more generically and about limb-girdle, and but yeah, ultimately, when it comes to care, it's individual decisions.
Thanks, Volker. We've had a really interesting question sort of come in, and also we had a question in advance around this, sort of linked to it. The question is why are why people living with limb-girdle muscular dystrophy on the clinically extremely vulnerable list? Our understanding at MDUK is that yes, some people with some types of muscular dystrophy will be on the clinically extremely vulnerable list. Everyone with a muscle wasting condition was classed in the clinically vulnerable category. But Volker, I don't know if you've got any thoughts you can share on the impact of COVID on people living with limb-girdle, and whether they are at particularly more risk.
Yeah. So, and again, we probably need to be a bit more granular here. So there are some limb-girdle muscular dystrophies and patients that are clearly on the very vulnerable list if their respiratory function is compromised, if their cardiac function is compromised. And then there are other forms where the respiratory muscle and the heart are very good. And I wouldn't really think that just because you're weak doesn't make you very vulnerable. But if you have respiratory involvement and cardiac involvement, yes. I should also maybe briefly comment, coming back to your previous question, what we see in terms of the progression in limb-girdle muscular dystrophy. And a lot of this is based on natural history data and the big trial that Anna and I were involved in, that we see that the progression can show kind of a sigmoid curve. So what that means is there's a phase in your life where you experience the progression more severely, and then it plateaus again. But often the weaker you are, the worse it feels if you lose a bit more strength. But then, at a certain stage, it doesn't really matter too much because you're already fairly compromised. So we see this as well, that during certain periods of life, the disease just feels worse and the progression feels more prominent.
Can I just interject there? So I think that's something to do with this relationship between if your strength is declining and how that impacts function. And we know that that folk can walk on, we've seen the MRIs, haven't we, Volker? You think, how are they walking? Because there's not a lot, that should still be working in their lower limbs, but somehow they're doing it. But there comes a critical tipping point which suddenly influences function. So you sometimes find that maybe the strength is is in a decline, but in terms of function, you'll notice a sudden drop and then a bit of a plateau, and a sudden drop and a bit of a plateau. And so that relationship is not completely tight. I think that's also what we're saying.
Thanks, Anna. And just turning back, we had a really interesting question around linked back to COVID, actually, in terms of is there any evidence that the vaccine may not be as effective in people with limb girdle because of the nature of having a dystrophic muscle and the fact that it's an injection through the muscle? Is there any data on that at all?
So for limb girdle muscular dystrophy, because we don't immunosuppress patients generally, it's not an issue. For those patients with limb girdle muscular dystrophy that are treated with steroids, and some of the more severe forms, and patients are, depending on the center as well, it could. So you might have less of a vaccination effect if you're on steroids. And for those people, a booster in vaccination is probably more important. But the disease itself, limb girdle muscular dystrophy, none of the forms really compromises the immune system. So it's more about, any treatment that you get.
Thanks, Volker. There's some advice and guidance on our website actually around COVID in general, but there's a specific section on vaccines which we work closely with clinicians on. And yes, there's lots of media talk about the booster jab, which will be eventually available to everyone, I think. But there is, yes, some people living with a muscle wasting condition might benefit from a third initial dose, which doesn't always make a lot of sense when you say it out loud. But I think the understanding is that your own clinical team will make contact with you if they think you're one of the people who would benefit from that third sort of initial dose to help boost the efficacy of the vaccine. But do jump on the MDUK website for further information, and we update that regularly because we are conscious that the situation does change sometimes. Louise, we've had some good feedback on your artwork behind you, so I'm pleased that came out. I wondered, have you been shielding during the pandemic, and kind of what's your experience been?
So I wasn't on the extremely vulnerable list or anything. So, I was just very careful, essentially. I mean, I have a 10-year-old child. So, in terms of them going to school, at the points when schools have been open, then, there's not sort of an awful lot that I can do if he brings it home. But yeah, there have been points when my anxiety was really quite high about it. And just the fear, it wasn't so much for me sort of, that I might get it and die or that I had any more chance than anyone else of that happening, the severe response. It was more, if I get this, oh my gosh, it's going to hit me hard, even if it's just pure down to like how much my muscles already ache. And, when you have a sort of flu-like thing, if I've had flu in the past, it just absolutely, hits me hard. And I still feel that now after having both vaccines, but equally kind of think, well, it is what it is, and I want to be able to live my life. But, I'm still a bit anxious in kind of crowded indoor spaces, and frankly, I'm not in such places very often. And because I can do all my work online, which I was doing previously, and I think that's one of the positive things about COVID for people with disabilities is, it meant that workplaces can be more adaptable to working on screens. I mean, I was using Zoom before Zoom was, popular because I did all my counselling online for myself in my work, making it manageable, but also for many of my clients who have disabilities. It just means that, because that whole thing of, I think that Anna mentioned about more things going online, even with physio, and I obviously appreciate that not everything can be done online, but, the amount of effort and energy it takes to get to hospital and medical appointments is, it's absolutely exhausting. And being able to pace yourself and know that, even, for example, this event, if I'd been asked to be on a panel that was face-to-face, I probably would have said no. But because I knew that I could do 2 hours online right now, then, that's brilliant as far as I'm concerned. So I think there are positives that have come out of it, definitely. But yeah, and I was also, if it's all right, just to pick up on what you were talking about, Anna, with the whole, like when your function just goes down, I think from a sort of mental health point of view, when you hit those points where suddenly you realize that you need to use a walker now, or that is where the loss really hits. And I think, just like anyone would understand about grief and loss generally, if you lose a person, that's how we understand it more, if it's through a death. a bereavement. It is a bereavement, and also initially there's just that terrible shock. That's often the first stage of grief, of course, for anyone. And sort of, I think we just need to be really patient with ourselves when we hit those markers, because you do eventually come to the place of acceptance about that new state of being, that new level of disability. But when it first hits you, it's like being hit by a wave, you know, a wave of grief, and it takes quite a while to figure that out and to go through the various stages of anger and depression over it, and then finally acceptance. So yeah.
Volker, you are the politest panelist we've had in the entire series, because you've got your hand up again, so I'll come to you.
Yeah, sorry for intervening it, but so just to follow up, because Louise mentioned it, and I saw this in the chat as well, that there are questions about life expectancy. And of course, that's very important. I would encourage everyone who is worried about life expectancy to actually talk to their specialist, ideally, because it does depend on the specific form that you are diagnosed with. The most common forms of limb-girdle muscular dystrophy do not affect life expectancy. So you can become very weak without dying because of the weakness. If the weakness affects your heart or your breathing, then of course life expectancy might be affected. So again, we can't make any general statement, but it depends on the form. And if this is a worry, and of course it is, I mean, you get the diagnosis of a genetic progressive disease, you know, will I die of that disease? It's important to, I think, address this with your consultant. And it's often something that people don't talk about, but it bothers patients, and therefore it's important that there is a discussion, and that people also understand there's a lot that we can do to actually extend life expectancy and quality of life with proper care.
Thank you, Volker. We're sort of moving into the final stages of the session, and I'm going to try and get through a fair few more questions. There's one question I think we can answer quite swiftly, which is just, is there a neuromuscular specialist centre in Scotland? I think the answer is yes. It's based in Glasgow, and there's also something called the Scottish Muscle Network that sort of helps connect services in Scotland. So do get in touch with us if you want more information about that. Anna and Jenny, sort of first of all, actually, Louise mentioned sort of the benefits in a way of the kind of virtual world opening up because of COVID. And actually thinking what you said, Louise, I saw something on Twitter very early on from someone living with a disability who said never again will they accept a conference organizer telling them they can't join remotely to speak. So I think hopefully that we live with that. But Anna, you mentioned the importance of encouraging people when they need to feel safe coming back into clinic. But I'd be interested in hearing from you, Jenny, and Volker about adaptations you've made to the service that may actually stay in place. So maybe some more virtual consultations where seeing a patient may not be essential, but having that conversation with them where they no longer need to come in might be helpful. Jenny, you've come off mute fatally for you, so I'll come to you first.
Yes, we did do attend anywhere clinics through the pandemic, and I think they are probably more difficult with children than with adults, because if we're trying to do an assessment, trying to engage them when they're hiding under the kitchen table and mum or dad are waving their phone at them was actually quite difficult. Sometimes you could do it, you could answer questions and you could look at some things, but some things just were not possible. And I think that's probably it's much easier with teenagers, and it's much easier with adults who are engaging themselves rather than, you know, I'm used to crawling about on the floor to get children to do things. So there are definite limitations. And I think the one thing that is, you know, some of the conditions we see, we do need to see every 4-6 months and hands-on. I think there are other conditions where we could probably do once a year face-to-face and once a year virtual. But I think in physiotherapy in particular, it's quite limiting on video. One of my colleagues who actually doesn't work in neuromuscular had a very interesting comment actually a few weeks ago, which I certainly hadn't thought about. And it was a teenager saying, oh, we're constantly told to be careful as to what we put online, and now you're telling me to undress. It's like, oh yes, that's quite interesting, but you know, it's quite hard to assess somebody's spinal posture unless you do that. So I think there's scope for it. I think it's harder in paediatrics.
Anna, anything to add to that, Anna?
Not really. I think keeping the mix can be very useful because some of our individuals live a long way away and there can be specific reasons why they don't want to come to clinic. Me and Volker have had some very funny experiences with diagnostic clinic using a video link. We've had some successes saying that on our diagnostic clinic, but nothing in that respect will replace like doing a full muscle exam. It's a little bit like saying, well, can't we just replace physiotherapists with machines? And you can, but you'll miss out because it isn't just about measurement, it's about management. And you need to be able to look somebody in the eye when you're talking about very sensitive and difficult things. And when you're asking individuals to try things that are very difficult, you need to be tender. You need to be considerate and you need to be realistic about what you really need that for. So you do still need that face-to-face, and there's much to gain from it. But I hope we will keep that flexibility going forward. Someone did share with us in the first month or so of the pandemic that they'd received a letter inviting them to their MRI scan to take place via the phone, which I thought was optimistic. So hopefully that kind of adaptation has been worked out. Yeah, Volker, it sounds like so yeah, obviously the physiotherapy, the physical side of physiotherapy, and you'll need to see patients face to face for some things. But have you used sort of virtual consultations a bit more as a result of the pandemic? Is that something you might continue with?
Yeah, I think for some of the remote assessments that or remote clinics that we have, so we have outreach clinics throughout the north of England. It might be more convenient for both the patients, but also the entire team, and more effective to do this remotely and continue this remotely. And as Anna said, I think what we have seen as well is that many patients feel actually very comfortable in their home environment, and they are more willing, coming back to what Jenny said, to undress at home than in a clinic. So, and I'm just thinking about when pets are around as well, dogs and cats, and you see them running, and you can tell that the patients feel more comfortable there, and the kids are there, and your spouse is there. So there is a lot of good in that. And I mean, Louise mentioned this. She used Zoom before the pandemic. Pandemic has just pushed us in this direction. And so we are currently also working now around better remote assessments, and can we do respiratory function, for example, at home? The MRI, that will be tricky, but in terms of some other assessment, and I would even think cardiac function, ECGs can probably in the future be done at home, and you just have your data on an app, and that is transmitted to the clinic. We're not quite there yet, but I think we're working on it.
Thanks, Volker. I think we've got time to squeeze one more question in that came in advance, because I think it's quite an important issue. But it was around just a question around pain management, and any advice around sort of pain management, both prescription medicine, but also any alternative therapy or complementary therapy. Volker, if I start to you, various people are nodding, which is helpful. But if I start with Volker, and then if anyone else wants to come in, that'd be great.
So, I mean, pain is often probably something that is not discussed enough. We focus a lot on weakness, and we know that some patients tell us, I'm not worried about not being able to walk, I'm worried about my pain. That is actually my biggest problem. And the neuromuscular specialists might often be a bit conservative because they're not pain specialists, but that there are clearly pain management aspects that need to be addressed at each clinic visit. Physiotherapy can be one form of pain management. Some people though feel that pain gets worse when they do exercise. Depends a bit on the type of your condition as well. It's not necessarily always the best thing. Traditional pain management in terms of drug treatment is something that many patients do anyway. They say, well, I'm taking ibuprofen or paracetamol. And so that there is a clear guideline on how you escalate this in terms of drugs if the pain doesn't respond to, let's say, paracetamol or ibuprofen. So very important to address this with your clinician, whether it is something, and your physiotherapist, whether it's something that requires drug treatment or you know, a wheelchair adjustment might solve the problem, or insoles, or so get the multidisciplinary team involved and make sure that you talk about pain.
Thanks. Thanks, Volker. Anna or Jenny, have you got anything to add on that?
I think one thing is sometimes addressing pain prophylactically, particularly with positioning. So lots of people have wheelchairs with recline or tilt facility, for example. And I was saying to them, you know, particularly when they're at school sitting in it all day, every 5 minutes, use that facility and change your position, because back pain is a big issue. And it's easier to try and adjust your position and try and prevent the pain rather than dealing it when you've got it. And exercise, quite often people are reluctant, thinking it's going to be painful, but it's a very individual, getting the right amount of exercise. That exercise actually can improve pain, providing, as we've discussed before, you don't overdo it. So positioning in bed as well is really important. As I said, changing position throughout the day. Having stretches done, often children don't like it because they think it's uncomfortable, but actually the contractures are painful. So you're trying to address it as well as when you've got the pain, but to try and delay that happening.
Thanks, Jenny. That's really helpful. I'm afraid that's all we've got time for today. It's been a fantastic session. A huge thank you to Volker, Yalda, Anna, Jenny, and Louise. Thank you as well for everyone who's been engaged in the session and sending in questions and comments. There was some really people just reflecting back on their own experience in the comments, which was really helpful. And I definitely encourage people to get in touch with us if you'd like to be part of a muscle group, or just to understand a bit more about how we can support and connect you with other people. Louise, I'm pretty sure I'll be seeing the artwork behind you in an MDUK auction in the near future, so thank you very much. But it's been fantastic to have you all with us, and Louise, thanks for sharing your personal perspective as well, in particular, and being so open with the audience. So I thank you as well to our sponsors and to our panelists, and yeah, bear in mind that there'll be a full recording of this available on the website over the next couple of days, along with the rest of the Muscle Matters series. So enjoy the rest of your day. Thank you for joining us, and do keep in touch with MDUK if you think we can provide any help or support. Thank you, everybody. Take care.
Thank you.
Bye.
Bye-bye.